And Dr. SUMITA.
Yes, sir. Good morning. Glaucoma, particularly advanced stage, advanced glaucoma is a very difficult situation to deal with because not only the patient but also the caregiver, it is very difficult to maintain them. And definitely for the treating physician, it is a challenging situation. So first of all, we have to know what could have been done to avoid late presentation, which we all do not want the patient to have. So I don't have any financial disclosure to make. The magnitude of the problem is really huge. EMGT and there's CIGTS, like all these hallmark studies, they have found that almost 10 to 33% of the patients which present to our clinic are either blind in one eye or in advanced stage, either in one or both eye. So this is a very huge problem. So we have to know what to do so that the patient will not reach this stage. So why a person reach this stage? It can be failure to detect glaucoma at an early stage, that is a delayed diagnosis. It can be inadequate or improper treatment, or it can be the non-compliance to the treatment on the part of the patient. So delayed diagnosis is very important. Almost 50% of the glaucoma patients in a developed country and around 90% in a developing country like ours, they remain undiagnosed. What is the cause again? It can be due to the lack of effective screening strategy. It can be due to delay at the patient level or even delay at the treating physician level. That is a misdiagnosis on the part of the treating physician. So lack of effective screening strategy. It's not cost effective or feasible for population screening for glaucoma, but we can screen the high risk patients like those who are diabetic, those who have trauma, those who are myopic, or we can do opportunity screening with the other tests like in the old days screening. But nowadays, artificial intelligence and deep learning have come, so we hope in future they can help us in doing screening for these glaucoma patients. So delayed at the patient level can be either due to infrequent eye examination or due to some misconception on the part of the patient. Glaucoma being an asymptomatic disease, the family history, if there is lack of family history or there is lack of frequent visit to the ophthalmologist, they are the major risk factors for delayed presentation. And most people usually require change of spectacles or reading glasses in their 40s. So this can be taken as an opportunity to diagnose any age-related ocular problem. But sometimes individuals without any formal training also, they sell spectacle. So this opportunity is lost. So there is certain misconception, like patients think that hazy vision is a normal aging process, so there is nothing to worry, and patients think that it is due to cataract only, so when it is mature only, they will get it operated. That's not the case always, and patients sometimes also think that I am not having any symptoms, so why should I test for glaucoma? So these conceptions have to be clear from the mind of the population so that we can have some early cases. Then delayed diagnosis can be due to the misdiagnosis on the part of the treating physician. It can be due to over-reliance on the single IOP measurement. We see a lot of ophthalmologists, they see that the pressure is low. It's not 21, so it's not glaucoma. But 21 is not the magical number. It is only a statistical average. Moreover, IOP alone has its limitations, and it depends upon the central corneal thickness. And there are also IOP fluctuations. So we have to keep those things in mind before taking only IOP as a reading. Moreover, threshold for IOP-induced damage, it varies with the patients even. So that same IOP amount may be sufficient for someone, may not be sufficient for others. And the in glaucoma diagnosis, the cornerstone of diagnosis is the studying the optic disc. So many causes of glaucoma are being missed just because optic disc was not looked at. The glaucoma optic neuropathic evaluation study, which assesses the reading ability of the fundus picture, they show that 20%, almost 20%, that is 1 in every 5 disc photographs were underestimated for glaucoma likelihood. This is not very encouraging scenario. So what are the key factors that led to their underestimation? It can be due to underestimating the vertical curve disc ratio, or it can be missing the retinal nerve fiber layer defect, disc hemorrhage, and neuroretinal rim loss. Disc hemorrhage is a very important finding in glaucoma or in glaucoma suspect, because that indicates that the patient's glaucoma is progressing and we should augment our treatment. And vertical CD ratio in inferior and any rim loss, and it be superior and inferior, they are indication that the actions of the retinal nerve fiber cells are damaging. So we have to think that into account also. And RNFL defect is one of the earliest signs of glaucoma that one should never miss. The missing angle closure component is very important in our country because PSEG is common in Asian countries and it carries threefold increased risk of severe bilateral visual improvement in comparison to primary open angle glaucoma. But the common misconception is that angle closure glaucoma presents only as an acute attack. But subacute angle closure glaucoma also can lead to chronic angle closure glaucoma, causing a lot of visual disability. Only gonioscopy and timely laser iridotomy will halt the disease process. In our practice, we see a lot of glaucoma patients who are diagnosed to have primary open angle glaucoma, but in actual fact, they are primary angle closure glaucoma. They are going on putting increased number of anti-glaucoma medication, but land up in advanced stage of the disease. Their vision could have been saved by just only a timely gonioscopy and timely peripheral iridotomy. So this has to be taken into account also. Many other systemic conditions and medications like diabetes, hypertension, thyroid eye disease, and steroids, they also cause glaucoma. And multiple medications for other conditions, they can also precipitate an acute angle closure glaucoma like MAO inhibitor, tricyclic antidepressant, antihistaminic, and mediatrics. This also have to be kept in mind. So overlooking the signs of secondary glaucoma also will land us in having the patient in an advanced stage because pseudoexfoliation is very common in our part of the country, and particularly it is important because its conversion to open glaucoma, PXG, is almost 50%, and the glaucoma due to pseudoexfoliation is very notorious that it progresses very rapidly and it usually does not respond to medical treatment that well. And moreover also uveitis, there are dual change we should see. Can be the glaucoma can be due to the medication itself like steroids, or it can be due to the disease process. And sometimes if we miss the pupillary area neovascularization, we will land up in very advanced stage of neovascular glaucoma, which is really not responding to treatment. So we have to look at, before the dilating the pupil, particularly in diabetic patient, the small amount of fine blood vessels in the pupillary area. And we have to take the history of steroid indication also, and trauma also have to be evaluated. So there can be underestimate the severity of the disease damage because target IOP is dependent on the baseline damage, and underestimating severity will lead to setting a higher target pressure, hence less aggressive treatment and disease progression. So we have to stage the disease properly, because if we see any field defect, then the glaucoma is no more in the very early stage, it is already in the advanced stage. And seeing a notch or seeing a disc hemorrhage will alert us that we have to augment our treatment. And IOP reduction is not sufficient, then also patient will lead in the advanced glaucoma stage, and we have to take care of the IOP peaks. 24 hours IOP monitoring is best, but it is routinely not feasible, and we can perform DBT during the office hour. And water drinking test is also another very good test which we can do that will show us the IOP peak. So for an asymptomatic disease like glaucoma, ensuring compliance is very much important, because without compliance, the disease progression, the disease will progress to its advanced stage and we cannot do anything about it. So late presentation of glaucoma is an important risk factor for glaucoma blindness, but blindness is not a certainty in patients with advanced glaucoma. So we have to deal with it correctly so that patient will retain whatever amount of vision he is left with. To discuss with that, we have the next speakers. My next speaker is Dr. Prof Bass, who is going to tell us how monitoring is important, because it is different from the routine cases. Over to Dr. Manes.
Thank you, Professor. Thank you, Professor SUMITA. You have covered practically all the aspects why we face the problem of late diagnosis of such patients. They come very late. Presentation is very, very late presentation. So I will have some question to Dr. Pradeep. What do you think, what is the commonest cause in our setup that the patient present to us so late?
See, the biggest problem in our population is that the patients are not aware of the condition. So we have to educate the mass population about the glaucoma, and how we can do only by organizing the camps at the various remote places. If you detect glaucoma early, then obviously you can prevent the blindness caused by the glaucoma. Remember one thing, that primary open angle glaucoma and normal tension glaucoma, they are not so notorious conditions. They progresses, but they progresses slowly. The most notorious for causing the blindness is angle closure disease and secondary glaucomas. Secondary glaucomas are pretty common in our country, particularly the pseudoexfoliation, pigmentary, steroid-induced. Steroid is used right and left, particularly in a pediatric patient for vernal keratoconjunctivitis. So remember one thing, that there should not be steroid abuse in any condition. If there is not a steroid abuse, then at least in pediatric patient, the blindness caused by the glaucoma can be prevented for a very, very large extent. But for early detection, you have to reach to the population, whosoever are suspect, bring them to the base hospital, do the detailed investigation. Don't ever forget to put the gonioscope in each and every patient who are suspected to have glaucoma. In spite of very deep anterior chamber, they may have an angle closure element. In these patients, if you do the laser peripheral iridotomy, then you may save these eyes from going into blindness.